Hi, my name is Dr. Shoaib Malik from Maxofficial Institute of Implantology. This lecture is about occlusion for implant dentistry. And exactly this topic is why I feel like the general dentist should have a nice complete package when they place their implant because they're in a unique position to not just place the implant, but to be able to restore it. And that gives you a great advantage because for us as a surgeon, I have to communicate back and forth with the GP on what their way of restoring would be. Either would be a screw retain, cement retain, bar, clipped, porcelain fuse, and all of those make a difference in surgical way how you're going to place your implants or have some type of a contributing factor. But being a general dentist, since you're going to restore it, it gives you a nice continuation because you can have a complete one thought in your head when you're actually placing the implant and being able to restore it and true implant it that way. So again, this is one of the great advantage that general dentist has, or you guys do, and take advantage of it. So what I'm going to do today is, you guys already know about occlusion. You work with dentures and bridges, so I have a good concept of that. But we're going to try to incorporate implants and how they might differ and what kind of special things you have to worry about when you're placing implants and how that occlusion can actually start dictating the type of implant or the treatment plan you're doing. So let's get started. So the first thing I want to go over is exactly what are the differences between implant and the tooth itself. And we kind of tell our patients, hey, they're pretty much exactly the same. It replicates the missing tooth. But from a surgical point of view, restorative point of view, there's some obvious difference. The net result might be the same, or our goal of the net result might be the same. But when you're treatment planning and you're trying to put the prosthetic to work with your implant in the patient centric relation or the occlusion they have, you need to understand the two differences. Obviously, this picture kind of gives a rough idea about the crown, the type of gingival attachment that differs from the natural tooth to the implant. So let's kind of get into a little bit more detail about what are the differences between the implant and the tooth and how that might affect our occlusion, our treatment planning. Well, the first one is pretty obvious, the periodontal ligament. We know that the natural tooth have a protective periodontal ligament around them, which acts as a shock absorber, and the implant does not. There's pulpal tissue, which provides thermal and pain feedback, which the implant does not. There's a neck, which reduces the stress of the ridge. So when you look at the tooth, you can see, especially on the interior teeth, you can see the nice little ridge. So all the forces are kind of pinned down to that small neck, so that can help reduce the stress on the ridge because the tooth itself is taking all the stress. Same thing with the roots because they are directed and they're conical and they go apically down. So the whole forces from the occlusion passes down to the roots. The size and the number of the root which help provide excuse me, the size and the number of roots which help provide surface area and support. So the more roots you have, the more surface area around you will have. There'll be good support for your for the teeth at least. The lamina dura, that's a nice strong bone that the periodontal ligament is attaching to that gives you a nice support of a protective cortical bone around the tooth. Obviously, there is some structural component because unlike titanium, tooth has not much, but somewhat of a flexibility with a dentin component. So these different manifest themselves into a different type of problems or issues that we have to deal with compared to normal teeth versus dental implants. So these differences are going to make somewhat of a part of a role, and I'll go over some of them how they can affect our working with our prosthetic or the type of prosthetic we're going to use or how we're going to cement it or screw retention it. So first, we're going to talk about the occlusion forces, and the reason I'll bring it up is because of the PDL. But first, just a kind of general idea about the Newton forces, normal massification force will go from, 9 to 180 Newton forces, and during our maximum bite, even during the parafunctions, for example, it can go up to 500. In daytime, when we're much more active, it's around, could be as high as 700. Men obviously differ from the women. And you can also see, like I was talking about, when you're talking about bruxism, for example, you can go up to 911 to 569, even at the incisor at 569. That's a lot of force, and that's a lot of stress that prosthetic has to endure during that time. And the reason I'm bringing up these bruxism and biting force, because there's a issue with periodontal not being there for the dental implants. So if you think about the periodontal ligament on a natural tooth, there's a nice connection between the periodontal and your brain. Every time you bite something, it guides it through. For example, if you're biting a biscuit, there's a certain type of shock absorber your tooth are going to go to when they kind of incise their way into a biscuit, that tells your brain exactly how much Newton force the muscle needs to kick in to complete that task, which would be 39 to 59. Or let's say when you're trying to eat something simple as like a soft cotton candy, you don't want your occlusion force to be around, let's say, 700 or 900 when you're trying to bite on a cotton candy. It needs to be adjusted on what you're doing. So this is what the advantage of periodontal ligament is. You have years of, you've trained your mouth and your muscles and your brain to work coincidentally with the feedback it gets from PDL to be able to guide how much mastory forces that needs to be required to close your mouth and finish the task. And you do lose that when you have implant. And slowly, you have to retrain yourself and your brain and your muscles to be able to achieve that same type of configuration in a system where you can predict how much biting force it would be. And I've seen that with full mouth restorative fixed cases, that it takes time. And there are times where you actually have fracture prostheses. We actually have made a measurement anecdotally and see their bite forces, how it changed before and after the prosthetic, because they actually lose that ability to kind of know when to stop or how much it requires to eat the same thing. So that's one thing we have to figure about and be careful about. When we talked about the morphology of an implant versus a tooth, we talked about ideally you want axillary loading, right? You want loading right on the top, so the forces are distributed all the way down the apex or into the bone itself. Excuse me. But the type of implant also plays a role exactly where those forces are distributed. When we have these implants that do not have threads, so they're more cylindrical, because of the shape of the implant, the force is distributed right at the apex. But these new type of implants that are very heavy threaded, most of the occlusion force are actually distributed right at the apex of these threads. So again, the type of implant also dictates what kind of occlusive forces and how they're distributed throughout the implant. And this is also why, you don't want, when we're doing an occlusion, you don't want any malocclusion or traumatic occlusion, because right here on the corner, if you're going up here on this side, the occlusion will pass down and it won't go down past on the apex on this side, but actually would have a more like a tilting effect where the occlusion force be on the crest here and on the apex over here. And that would lead to crestal bone loss, which is susceptible anyway when we're doing implant, and that's what we're trying to protect, because you don't want that vertical bone loss, which we accept some about 1 millimeter in the first year, but you want to protect it. And a traumatic occlusion can actually lead to crestal bone loss, even though you think you've done a great job of placing the implant. It was integrated, there was no bone loss, and as soon as you place your dentist or you place the prosthetic, all of a sudden you start seeing crestal bone loss. Maybe that because of the traumatic occlusion. So that's how important occlusion can be in correct restorative of occlusion in the success of the implant itself. And we have seen that in our practice. Just to kind of review type of occlusion, you need to have a good understanding. Balanced occlusion, where teeth simultaneously contact during both the maximum intercuspation and eccentric mandibular mastery movement. Usually it's recommended for a complete denture patient. Lingualized occlusion, have an idea what it's about. Understand the mutually protected occlusion, canine guided, excuse me, and is usually regarded as one of the better ones for natural dentition, and it helps prevent and dislodge the posterior and the interior so they're not being overloaded. The group function occlusion is also, it's the group function occlusion occurs when all the facial cusps on the working side contact the opposing dentition with no contact on the non-working side. So the reason it matters is because you want to have atraumatic and axial loading on your implant, and the more traumatic loading you have on your implant, the more likely you end up getting crust of bone loss or even dislodgement of your prosthetic itself, depending if it's screw or cement retained. But regardless, it has a internal weakness to be dislodged if it's traumatic occlusion. So if you already have a patient who has some type of malocclusion, it would be a great thing to do to have that occlusion taken care of before we actually start doing our implant prosthetic restoration, let it be full, large, partial, or even a single. So when we do that, what are generally the signs we're looking for that unstable occlusion? Obviously, joint pain, muscle pain, broken teeth, worn down teeth, mobile teeth, and periodontal defects. And especially people when you kind of follow up on the ortho patients, when things are not right, the occlusion is right now, you can slowly start seeing periodontal defects on the teeth. But generally, if your patient are showing most of these signs, then you might have to think about their underlying occlusion instability and see where the problem is and see if you can fix it before you actually start placing implants. So have them prepped up, have their mouth prepped up because there's some inherent weakness in implant. So we need to have the best overall condition inside the mouth before we actually start placing the implants. So these unstable occlusion can lead to parafunctional, which is bruxism, which can exceed the amount of bite force we talked about, almost to 900 Newton. So imagine patients that already lost their PDL, and you're trying to make a implant restorative full mouth prosthetic. That could even make it worse because they lost their PDL, and all that force will be generated on their prosthetic, which could have a fracture or even lead to an implant failure. So we need to avoid the unstable occlusion, looking at the symptoms of the patient, making sure this is not what's happening in the mouth, and give ourselves a best chance so our implant would succeed. One of the things when we were talking about placing of the implant, one of the key component is the crown height space. And I'm going to go over this for each type of prosthetic restoration and try to help out what's the minimum height you need to have to be able to achieve that type of prosthetic, because that can really make an impact on the prosthetic itself regarding how much height space do you have. So the crown height space is a distance from the occlusion plane to the crest of the alveolar ridge. Okay, not the soft tissue, but from the surgical point, distance from the occlusion plane where the teeth are meeting to the crest of the alveolar ridge. And that crest of the alveolar ridge is where your implant is going to end up being. That'll be the highest point of your implant as it sits into the bone. So that's what we're going to define the crown height space. This available space will determine the type of prosthetics and the material and the surgical technique. So that tells you how important that crown height space is, because it really dictates the type of prosthetic we're going to use, the materials that are going to be involved, and to some degree, even in some kind of surgical technique, if we need to over-engineer, under-engineer, or go with the basic, even sometimes tilting, or putting straight implants in a more advanced cases. So just from the basic part of it, when we're doing our implant prosthetic space requirement for fixed single crown, you need about 8 to 9 millimeter of an average 8 to 9 millimeter of space. With 3 millimeter of tissue height, at least minimum of 2 for biological width. Then you have your abutment collar, your abutment height 3 millimeter, and obviously you want some restorative material around it, and to compensate for that. So 8 or 9 millimeters, you need at least space for a single crown. So when you're talking about the implant prosthetic fix, like we just talked about, the ideal space, like we talked about, 8 and 9, you want to go more, the more it is, at least around 10, so you have more of that restorative material on the top, and maybe even the abutment height. In the posterior part, on the lingual aspect of the canine, you need at least about 10 to 12. The crown margin should be at least 2 millimeter, like I talked about it, for the biological width, above the crestal bone, to allow the connective tissue zone of attachment. So you never want to violate that. If you violate it, the body will make its own space, and you will actually lose your crestal bone, and the threads of the implants would be visible at that time. And you'll obviously have some inflammation and reactive inflammation reaction from the body, the defense mechanism. If minimum amount of crown height, then if you don't have enough crown height, then we recommended using metal occlusion to compensate for that, especially in the area where it's 2 or less millimeter of material clearance available for you. In the implant prosthetic space required that it has a bar clip for an overdenture. You need about a 15 millimeter. Again, the 3 millimeter we talked about, that's the most. You'll always need that. 2 for hygiene added. And the metal housing, the clip, or the whatever the bar you're using needs about 5. You need acrylic 3. And on the lingual part of the tooth, you need about 3 more. So you need at least 15 millimeter if you're planning to have prosthetic space for a bar clip overdenture. Implant prosthetic space requirement for the overdenture. So for the overdenture, you need, again, 3 millimeter for the biological. For the metal housing or the clip, you need at least 3 to 4. The acrylic and the tooth, same as before, 5, so you need 11 or 12. For implant prosthetic space requirement for the fixed detachable, now, where we put the screw in, now this is fixed, so even though we're saying detachable, but it is fixed, but it's screw retained. Ideally, you need to have 18, but you don't want to go below 15. If you go below 15, you're going to have problems, especially with stress fractures. So again, 3 for 3 for tissue depth. And for the metal framework, let it be the bar, it'll be about 8 millimeter, then acrylic on the top, and obviously from the lingual side for the tooth. So 18 is what you're looking for. 15 is the minimum. So you kind of have an idea, depending on the space that you have on your case. It might dictate what kind of prosthetic you're using. Now, what if you don't have right amount of space? That in some cases we can manipulate stuff, and if you have an excess crown height, which acts as a vertical cantilever, so it becomes a problem. So if you have too much height and you try to place a long crown, try to overcome it, it almost acts like a cantilever. And it shows that for every millimeter in crown height that increases, the force increase may be about 20%. So that's a lot of torque force that's going to affect the placement of the prosthetic and dislodgement and on the implant itself, which can relate to crestal bone loss because it'll be traumatically putting force on the implant area, at the crestal area. So, we have to be very cognizant of the fact of whatever we discussed before in the type of prosthetic we're using, and whatever the height length we suggested, to be in that ballpark and to try to overcome it. And making crown longer, it will actually have a destructive effect on the implant itself and the prosthetic. In case when it's diminished crown height, we can increase it by doing avioplasty. We can even do a root canal on the opposing teeth. Orthodontist impaction, again, hardly ever done that, but usually the crestal of the avioplasty on the crestal is one of the first things we do. You can also increase the video, but if you don't know the status of the TMJ, or if the patient has TMJ issue, or even occlusion issue, we don't recommend that. But usually avioplasty is one of the better ways to do it, especially if you're doing a full mouth, full arch restoration, either on the maxilla or on the mandible. So what are we looking for occlusion for a single implant unit case? Things that we recommend: you want to have a light infrared occlusion, eccentric occlusion, position on the posterior implant restoration. So basically what that means is you might want to have your occlusion, the crown itself would be slightly under the occlusion table. So therefore you have a light occlusion on the crown itself. So if you have an occlusion table, the top part of the crown is actually going to be a little bit below the occlusion. You also want a narrow occlusion table, ideally, and probably one of the more important things is to have an extra loading, like we talked about. You don't want traumatic loading on the side that can dislodge the crown itself and cause crestal bone loss around the implant. No or only minimal contact on implant restoration during mandibular excursions. So during mandibular excursions, we recommend no contact at all. So here's another difference between natural tooth and implant. You can use canine for guide. You can use canine guidance on implants. So you can't place an implant and use that implant in the canine region to have your mutually protected occlusion with the canine itself. So that's one of the difference. Minimum growth function on the working side, which is to be expected. The other key important decisions that we have to make when we're restoring the implant is either to use cement or screw retain implant. They both have their advantage and disadvantages. And the more we understand, again, the height, is cosmetic, the cost factor, all that makes a difference in making these decisions, but they also affect our implants. So just to understand a little bit of it, comparing the cement versus screw retain implant, a passive fit is more difficult, if not impossible, when we're talking about screw retain. And if people who have done full arch, for example, we know what we go through it. In the anterior screw retain crowns, the implant is placed more lingually to allow screw emergence through the cingulum area. So, which makes sense because you need some kind of an access device to be able to go through. And in the interior, you compensate it by going lingually, so your cingulum, screw would be coming out of your cingulum. The problem with that is it can cause a ridge lap, which could be a problem for hygiene and cleaning it up. Obviously, this is not the problem you have with the cement retain, because you can actually have your cement retain angularly right at the incisal edge, and so you won't have any cingulum or overbuilding of the cingulum, which can lead to ridge lap. So that's kind of one of the difference between when we're placing our implants and the way we're treatment planning is in beforehand. If you're planning to go either cement or screw retain, they'll give you an idea when you're placing your implant to go more lingually to compensate, have an angle abutment, and place the opening at the cingulum. Might be an issue with the hygiene, or we can have our implant right where we want the incisal edge and have the cement retain. If you're thinking about doing an immediate placement in the anterior zone, our recommendation is to have a one-piece screw retain restoration for single tooth. Um, it provides a good aesthetic, it's easy to retrieve, and it does not require the use of cement, because part of the problem they had in earlier implant cases when there was cement retained is that the cement would go into the gingiva, infragingivally, subgingivally, and it will cause irritation, swelling, and even bone loss, because the cement will kind of leak in through the subgingiva. Obviously, things have changed. Now you can have custom above and supergingivally that will make it easy to clean, but at the same time, it's still an issue that we have to deal with. But by having a one-piece screw retain, you're kind of avoiding that process altogether, but it also gives us the advantage to be able to retrieve it either when we want to change the crown or make sure it's you can easily clean around it. So that's kind of a good advantage. Not it's all not are gone with this screw retain, because you'll be able to have this big advantage of being able to retrieve it. So when are we looking to have a cement retain crown? At least 5 millimeter of abutment height is needed for a proper retention and resistance of a cemented retained crown, which makes sense. So you need to have at least 5 millimeter. You need to have enough surface area to be able to have some type of retention and resistance. So that's one of the requirements. If it's below 5, then we would recommend going through the screw route. But if it is, you can at least get 5 millimeter or more, you should be able to have a cement retained crown. Excuse me. It's a passive fit is easier to accomplish because it doesn't have to be perfectly right on top. Any indiscrepancies that you have, or there's a lab distortion that you have when doing fabricated, it can be made up because you have a cement space that can fill it up. And a passive fit is easier to accomplish in cemented restoration due to the die spacer. The die spacer creates at approximately 40, it's supposed to be micrometer, I'm sorry for that, 40 micrometer cement space, which compensates for the laboratory distortion. So makes it a little easier to have it nicely fit in, because even if you have discrepancy, it can be up to 40 micrometer can be filled up due to the cement. The other advantage of the cement retain would be its low cost due to the cheaper to fabricate, and you need less number of visits and less time during the visits when you're trying to put the cement retain crown, because how nicely it can passively fit in and doesn't have to be perfect, and our distortion can actually be filled up by the cement. So let's look at the indication for screw retain posterior fix restoration. So we talked about the excessive part or the leakage of the cement from the cement part that can cause the inflammation of the surrounding tissue. One of the indications for screw retain posterior fix restoration is if the implant shoulder location incompatible with the cement structure, for example, is an inaccessible, for malicious access cement removal. So in cases where there's a 2 millimeter submucosal, which you usually seen in the anterior teeth, you might have the margin underneath, and that could lead the leakage of the cement, and then cause inflammation. Also, the indication would be is if you don't have enough intermaxillary distance. We talked about how you need to have at least 5 millimeter or greater when we're doing a cement retention. So if you have less than that, an indication would be to go with the fixed route. If there's a reason that you're expecting things to be retrieved in later time or change, it's nice to have a screw retained, because unlike cement where you need some kind of dissolvable to dissolve the cement out, in screw retain, it's much easier because you just have to go through the opening and just unscrew it and be able to take it off and put it back on, take it out, put it back on. So that's one of the nice advantage for it. Also, one of the indication is the extended implant supported rehab involving numerous implants. So that helps it too, because then you can individually tie your implants up. Also, high overall level of complexity, non-parallel implants. So in cases, especially when we're talking about teeth in a day or all on four, where you're using multiple implants and some are angulated due to the anatomy consideration, screw retain becomes a nice choice of restorative. So what are the complications we're looking for from both of them? For screw retain restorative are associated with more complications than cement retain restoration. And mostly is because of this right here, because of the cylindrical loading due to the nature of the chewing and obviously consistently going back and forth. The screw retain restoration experience screw loosening and fatigue fracture. So that's one of the main reasons you see more problem with the screw retain compared to the cement is the loosening of the screw and the fracture due to stress. The frequency of screw loosening is reported to be from between 10 to 65%. This mainly occurs in the posterior area, which makes sense because that's where most of the occlusion forces are, or the most strongest occlusion forces are, and can also see in restoration and cantilevers. So single restoration and cantilevers. But again, if it is just screw loosening, at least we know we can retrieve it, open it up, and actually tighten it up. The other complication is the porcelain fracture in screw retain restoration is more prevalent due to the unsupported material around the screw access hole, which makes sense also. So these are some of the complications that could happen. Obviously, we already discussed a couple of them with the cement. Number one being the leakage of the cement itself and the height itself. If the height is not proper, your retention is not going to be as strong. So here's a kind of summarize both of them. Use of screw retain implant crown versus the cement retain implant crown, in what cases where we're looking at and what cases not. So it kind of reviews already some of the pros and cons we're talked about. But it also gives us an idea how, the type of inner space distance, the implant itself, how much bone do you have available can affect our restorative part and our occlusion part and vice versa. So all this needs to be understood and part of the treatment planning. And this is why these are the topics on the occlusion we're discussing now, and we're kind of prepping ourselves up later on where we actually start talking about surgical treatment plan, because understanding this knowledge, anatomy, and soft tissue management, all of these are a big component in taking our step into implant treatment planning and surgical protocol. So next we're going to talk about restoration of full arch based on height, based on the crown height space. And we already talked about the single units. Now we're going to discuss more on how to evaluate space and type of restoration based on the crown height space. So if there's less than 50 millimeter, we recommend porcelain fused metal is recommended. If the distance is greater than 50 millimeter, if you are trying to have a PFM and the distance is greater than 50 millimeter, that could lead to a porcelain metal fracture. And the reason for that is because the metal substructure, it becomes difficult because of various of cooling and heating to be could be difficult for the lab to bake the porcelain on the metal substructure. So it'll be an even part, there might be space, and then that can lead to a fracture. So our recommendation is that if you have less than 50 millimeter space, crown height space, we recommend going to the, especially I'm talking about the full arch restoration, to go with the PFM. But if the space is greater than 15 millimeter, we recommend a hybrid fixed prosthesis, which you need a bar and then have the acrylic and the tooth on top. So in this case, if you're greater than 15 millimeter, you want to go with the hybrid fixed prosthesis, and you do not want to use Hybrid prosthesis if it's less than 15 because there's not enough supportive structure, because you need certain amount of acrylic on top of this prosthetic to be able to stand it. So if you don't, you will get stress fractures on your prosthetic part of it. So our recommendations are, if it's greater than 15 millimeter, go with a hybrid fixed prosthesis, and if it's less than 15 millimeter space, you need to think about going into the PFM route. The AP spread is also very important. You need to be careful of your cantilevers in a full mouth restoration. Make sure you do not exceed the 2.5 times the AP spread when we're talking about your cantilever. Also be careful when when you're looking at your patient and the arch has a square and has a taper form. Make sure you're doing it conservative cantilever on that, and maybe even a little bit of more engineering, so you can't put stress on the cantilever itself. And one of the last things I'm going to talk about is the type of dentition and the recommendation for the occlusion type. So, just to kind of have an idea, it's not one size that fits all. So if a patient, for example, is a dentulous who needs a full bone anchored prosthetic, our recommendation is to use mutually protected occlusion and to have attain posterior distal occlusion with mutually protected occlusion. If you're thinking of using an overdenture prosthesis, our recommendation is balanced occlusion. For Kennedy class 3 and 4, group function is what we recommend, and for Kennedy class 1 and 2, again, we recommend the mutually protected occlusion with posterior disocclusion is recommended. So, again, when we started this chapter, we talked about how important a role of occlusion have in not just placement of the implant, not just restorative of the implant, but really on the whole treatment planning. And it's a back and forth where we talked about just the fundamental differences between the implant and the natural tooth, how the morphology of the tooth helps protect itself with the PDL and the conical shape which implant lacks. So we have to make up for that. And knowing the fact that since it doesn't have PDL, the occlusion force initially is compromised, so you do not want to put excessive loading on it. And so based on that, we were thinking about how to make a prosthetic on the top that has enough retention strength to be able to take those forces. And depending on where they are, interior, posterior, if they're doing full arch, we talked about, for example, in full arch, you need 15 millimeter space or more than you need a hybrid fixed prosthesis, or if it's less than 15, you have to go to PFM. So, you can see how now, even from the occlusion part, from the restorative part, how much knowledge you have and what you should be thinking when you're doing your treatment plan. And now you're going to take all that knowledge and add it to this addition of surgical knowledge we're going to talk about, the bone quality, the type of bone. And then you can, start thinking, connecting those two dots together to be able to have a full-fledged implantologist who kind of knows from the start to the end and all the nitty-gritty in the middle. And once you understand these concepts, what we talked in this chapter, which I think is extremely important, bone morphology, soft tissue management, and then you understand that doing the implant is probably the easiest part. This is what makes and break our treatment planning. And if you can really understand these concepts, you'll have such a nice predictable result when we're actually placing implant, because you understand the crown height ratio. You understand why we need more space to be able to do it, and why that biological width is important to be preserved. So, it gives me pleasure when I see my general dentist, because, unfortunately as a surgeon, we do one part and then here we go. It's really joy when my students who have actually learned and they show me their whole cases to have a full, nice understanding of the treatment plan. And hopefully after this lecture, you feel comfortable understanding that part also. All right, thank you very much.